Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Longitudinal Changes in Depression Symptoms and Survival Among Patients with Lung Cancer, a National Cohort Assessment by Sullivan et al. My name is Paul Duberstein, and I am Professor of Psychiatry, Medicine, and Family Medicine at the University of Rochester Medical Center in Rochester, New York, USA. My specialties are mental health care and palliative care. Anyone who has experienced grief, which is to say just about everyone at some point in their lives, will have a vague sense of what depression feels like. But grief is considered normal, and so, in some circumstances, is depression. Indeed, it is often difficult to distinguish a normal depression from clinically significant depression. Moreover, no two people will experience clinically significant depression in exactly the same way. Some will feel sad and blue. Others will feel angry and irritable. Some might eat too little and have difficulty sleeping. Others will overeat and oversleep. Some will be racked by guilt and consumed by self-hate. Others will never have such thoughts. Some will have recurrent, intrusive thoughts of suicide. Others will swear they have never in their lives thought of suicide. Some people will experience numerous symptoms of depression that last for a couple of weeks, and others will live nearly their entire lives never quite able to shake off the blues. It is as though depression becomes part of their identity, core to their personality. If you are an oncologist and are unsure how to assess or manage depression in your patients, that is understandable. The arbitrary boundary between normal and abnormal depression and depression's many manifestations make it challenging even for highly experienced specialty mental health clinicians to assess, diagnose, treat, and manage. But depression is too insidious and noxious to be left to specialty mental health providers alone, a tiny sliver of our sprawling healthcare system. If you are an oncologist and think that it isn't part of your job to listen to your patients talk about their inner lives, their depression, their sadness, I urge you to reconsider. As Sullivan and colleagues show, depression can be lethal. Influential clinicians have known for a long time that depression can suck the life out of patients, figuratively and literally. In 1812, pioneering psychiatrist Benjamin Rush, a signer of the Declaration of Independence, observed that, quote, "Dissections of persons who have died of grief show congestion in and inflammation of the heart with a rupture of its auricles and ventricles," unquote. More than 70 years after Sigmund Freud speculated that, quote, "the duration of life can be appreciably shortened by depressive affects," unquote, the first study on depression and cancer mortality appeared in the Journal of the American Medical Association. The year was 1979. When Martin Pinkwart and I published a meta-analysis in 2010 showing that depression confers risk for mortality in cancer, there were more than 60 prospective studies on that topic. In this context, the article by Sullivan et al. Is a significant contribution to an already robust literature. They studied symptoms of depression as assessed by 8 items on a depression symptom scale called the CESD. They show that depressive symptoms increase risk for mortality of newly diagnosed patients with lung cancer enrolled in the well-known Cancer Care Outcomes Research and Surveillance Consortium study. That study is known as CANCORS. At baseline and follow-up, depression symptoms were associated with increased mortality among participants with early-stage disease. At follow-up, depression symptoms were associated with increased mortality even among participants with late-stage disease. 4 features of their analyses are noteworthy. First, they studied a demographically and clinically representative cohort. Second, their approach to covariate adjustment was quite strong as they adjusted for the effects of potential confounds that are often overlooked in research on depression and mortality, including socioeconomic status, comorbidity, alcohol abuse, smoking, and prior psychiatric history. Third, they conducted numerous sensitivity analyses, including a particularly important one that excluded CESD items that could reflect the physical symptoms of depression, cancer, or comorbidities, such as fatigue. That analysis showed that psychological symptoms such as depression, sadness, unhappiness, loneliness, and lack of enjoyment conferred mortality risk. Fourth, they took advantage of the second wave of data collection in CanCORS about a year after study entry to show that people who scored 4 or higher on the CESD at study entry, but subsequently scored lower than 4, which was about 10% of the sample, were not at elevated risk for mortality. From this latter finding, the authors offer a clinical take-home message mentioning the potential importance of, quote, effective mental health treatment, unquote, and touting the, quote, impressive outcomes, unquote, of collaborative care interventions. It is surely desirable for cancer patients to have access to evidence-based mental health interventions. Still, the science can't tell us why depression scores in a minority of CanCORS patients declined across an arbitrary threshold over a 12-month period. Patients may have received good news, joined a support group, deepened relationships with family members and friends, increased their church attendance, started a regular exercise or yoga routine, and simply accommodated to the reality of life with a devastating illness. The absence of relevant data in CanCORS on the interval between study entry and the 1-year follow-up makes it impossible to draw conclusions about the potential value of mental health interventions. The author's enthusiasm for collaborative mental health care must be further contextualized. Collaborative care for depression, which by definition requires depression screening, has been shown to be effective for patients diagnosed with major depression. But Sullivan and colleagues studied symptoms of depression, not major depression. Data on major depression are not available in CanCORS. Moreover, the United States Preventive Service Task Force recommends depression screening only, quote, when a system is in place to provide effective care, unquote. Unfortunately, many oncology providers are unlikely to have ready access to collaborative care teams because they work outside of major academic health centers or integrated healthcare systems, such as the VA or Kaiser Permanente, where collaborative depression care is more frequently available. However, even under well-resourced conditions, there is a paucity of clinical trials to support a net benefit of depression screening. Both the UK's National Institute for Health and Clinical Excellence and the Canadian Task Force on Preventive Healthcare refrain from recommending routine depression screening. Don't get me wrong. Getting patients who are suffering from major depression into timely, affordable, accessible, evidence-based mental health treatment is important. But even when patients are in mental health care, oncologists must still be able to listen to their patients talk about emotions. A concern I have with routine depression screening is that it could send a message to patients and oncology providers that cancer patients' inner lives could somehow be siphoned off and outsourced to specialists. This could deprive clinicians of an opportunity to leverage the therapeutic relationship and provide care that is responsive to patients' carefully considered goals and priorities. Do not underestimate the role of the therapeutic bond with your patients. One study showed that a strong alliance between patient and oncologist could potentially mitigate suicide risk. Oncologists have always had healing relationships with patients that extend beyond the care of cancer to the care of patients' hearts and minds. The impact of depression screening on the patient-oncologist relationship must therefore be considered. Depending on how it is presented, routine depression screening could have the unintended effect of alienating patients as well as providers. A study I worked on showed that many patients concealed their symptoms of depression from their doctors because they were afraid they would automatically be prescribed antidepressants. Nearly a decade ago, the National Cancer Institute commissioned a monograph on patient-centeredness. The Institute of Medicine similarly called for improvements in patient engagement, particularly with respect to end-of-life care. It is difficult, if not impossible, to engage patients in patient-centered care without listening to them, eliciting their priorities, and exploring their inner lives, their fears, uncertainties, and vulnerabilities. And it is difficult, if not impossible, to tread into this territory without also creating space for patients to talk about sadness, grief, loneliness, hopelessness, regret, existential malaise, fears of dying, and lack of joy in their lives. Most patients want to be heard. They want you to listen carefully and bear their pain compassionately, respectfully, even silently. Few are looking for an automatic referral to another specialist who will prescribe yet another medication. Listening is a skill that can be developed, and this may be especially true in cancer care. In contrast to other medical specialists, oncologists have far more opportunities to participate in psychologically sophisticated communication workshops. Depression symptoms are rarely visible, and there are no definitive diagnostic laboratory tests. Nonetheless, depression can be lethal. The paper by Sullivan in this issue of JCO drives that point home. As societies worldwide struggle to muster the political will needed to dedicate resources to decrease depression's toll, oncologists occupy a unique niche. Not only does cancer increase the risk of depression, but depression in cancer patients confers risk for adverse outcomes. Listen carefully when your patients talk about their emotions. If you believe the patient might meet criteria for major depression, and you are fortunate enough to have access to on-site mental health providers who do not have lengthy waiting lists, ask the patient if they want a referral. If on-site mental health care is not readily available, ask the patient if their primary care provider is aware of their depression. If not, inform the primary care doctor. In most cases, you will not need to make a referral. You will just need to listen attentively. Empathic listening has been rightly referred to as emotional labor, and it can be draining, but the deep rewards for oncologist and patient make it worthwhile. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.